So let's talk a little bit about blood now. The functions of blood. The functions of blood are mainly to transport materials throughout the body. In order to be able to be transported in the blood, these molecules must be either soluble in water or bound to a carrier molecule that is soluble in water. If it is not soluble in water, and if it is not bound to something soluble in water, the materials will not be transported through the blood, as the majority of blood is actually water. Blood is also used to regulate a number of physiological functions, including body temperature, as well as through transportation of chemical signals, systemic functioning. This ability to transport chemical communicators, hormones, cytokines, is used for both systemic and global adaptations, as well as systemic and global homeostatic regulations. So what are the contents of blood? Well, we look at it in terms of two forms. The two forms that we look at are the liquid form, which we refer to as plasma. Plasma is primarily water, which is why anything that's going to be transported in blood has to either be soluble in water or be linked to a carrier molecule that's soluble in water, along with proteins, salts. When we talk about salts here, what we're meaning is electrolytes and nutrients or metabolites, as well as the cellular portion, which we refer to as the formed elements. The formed elements are the erythrocytes, those cells that will be gas-carrying molecules or gas-carrying cells, and the leukocytes, which are the immunological cells. In terms of total volume or total mass, blood is approximately 8% of total body mass or total body weight, which within the normal range of people is somewhere between 4 and 6 liters. This is dependent upon the mass of the individual, which means that the total blood volume is going to be dependent upon the size of the individual. Generally speaking, females will have a smaller total blood volume than males, not only in terms of the total blood volume itself, but also in terms of the actual cellular component part, in particular the erythrocytes. The principal reason for this is because females are smaller in general than males. However, if we look at equal-sized individuals, they will have equal volume of plasma and equal volume of blood. So let's take a look at the composition of blood by volume. If we look at it in terms of where we find blood, we have two distinct regions that we're going to find the blood. We're going to find the blood either in the venal side or in the arterial side. 64% of all blood is found by volume in the venal side. This forms what's referred to as the blood reservoir. We're going to need to remember this when we talk about hemodynamics, in particular vascular pressures. 13% of blood will be found in the arterial side. About 7% will be found in both the heart as well as in the capillaries. And about 9%, give or take a little bit, will be found in the pulmonary system. Within the total 100% of blood, regardless of where we find it, about 45% is going to be hematocrit. The hematocrit is the formed elements. This includes the erythrocytes, the leukocytes, and the thrombocytes or the platelets. And about 55% is going to be in the plasma, with about 90% of that being water. So let's delve a little bit more into the issue of hematocrit. Now what we have to note is that the hematocrit will change based on a change in plasma volume, as it is a examination of the blood based on a percent of blood comprised of formed elements, which means that if we have a change in plasma volume, we're going to end up having a change in hematocrit. Most changes that we see in hematocrit are not due to cellular changes, as most books talk about, but is actually due to changes in plasma volume. Plasma volume will change drastically based off of environmental conditions as we have a shift in fluids so that we can keep the body within normal homeostatic levels of body temperature. When we talk about hematocrit, we're talking about the relationship between the formed elements, the red blood cells and the white blood cells, or the erythrocytes and the leukocytes, as well as other cellular components such as the platelets, in comparison to the total blood volume. Most of people will have a range of between 35 and 50% for hematocrit levels. These are dependent upon distinct demographics as well as distinct physiological issues. Like I stated before, the hematocrit is going to be relative to any type of shift in plasma volume, which means that the more active the person is, they're going to have a greater shift in plasma volume, and thus will have a elevation of hematocrit. And with demographic issues, we're talking about changes or differences that we see with gender, as well as in terms of evolutionary history, where we see people arise from. As people who are from higher elevation in terms of their evolutionary history will have a greater percent of hematocrit possibly due to the necessity to have greater oxygen carrying capacity. This is especially seen with people who go from lower elevations to higher elevations, particularly acutely, where people say move from Connecticut to the Rocky Mountains, where in that move they have a diminishment of atmospheric oxygen pressure, which means that they're going to have to increase the amount of erythrocytes there in order to maintain a normal level of oxygen carrying capacity within the blood. So here we're looking at the breakdown of the blood and into the actual hematocrit. So once again, we're looking at the 8% of total body weight coming in the form of blood or serum. 55% will be in that plasma, where 90% will be water, and the remaining will be formed of proteins or dissolved elements, here referred to as other solutes. And the 45% will be in the formed elements. Once again, we have that range. Of the formed elements, a majority will be in the form of erythrocytes, whereas a minority will be in the form of the leukocytes. This percent of leukocytes will be based off of the state of immune activation as well as growth signals. However, the majority of leukocytes, regardless of these signals, should be neutrophils, followed by lymphocytes, monocytes, eosinophils, and basophils. So if we look at the origin of all of these types of cells, they're all going to come from what's known as a pluripotent stem cell. The pluripotent stem cell is a stem cell from fetal development that can form any type of bone-derived connective tissue. In this case, they're going to end up forming blood cells. There are two distinct types of blood cell lines that can be formed from the pluripotent cell. They're referred to as the myeloid or the lymphoid stem cells. The myeloid stem cells, if we get stimulus from EPO, will end up forming the erythrocytes. If we get stimulus of TPO, they're going to end up forming the thrombocytes. And if we get stimulus of what's referred to as thymosin, a growth factor, an interleukin factor, or an immunoglobulin factor, will form either the granuloleukocytes, the eosinophils, the basophils, and the neutrophils, the macrophages, the monocytes, or the lymphocytes. The lymphocytes are going to come from that lymphoid stem cell and will form either the T lymphocyte, usually referred to as the T cell, or the B lymphocyte, usually referred to as the B cell. And then we also get what's referred to as the natural killer lymphocyte, or the NK cell. So let's delve into the erythrocyte itself. The erythrocyte is the gas-carrying cell within the blood. During the maturation process, oxyhemoglobin molecule, or actually the hemoglobin molecule, there's 4 different variants, and we'll talk about that in a second, is going to end up displacing the nucleus within the cell. As it displaces the nucleus, there is nothing there to support the cytoskeleton of the cell, and it leads to a collapse of the central third of the cell, which forms a biconcave shape. This biconcave shape is important because it's going to increase the surface area for the cell to interact with gas, as well as increase the area that the hemoglobin molecules can reside. So if we look at the erythrocyte, notice the biconcave shape, and notice the central collapsion of the cell. It's that central collapsion of the cell that's going to lead to the increase of surface area for gas exchange as well as for hemoglobin collection. Notice the size of 7.5 microns by 2 microns. This is important because it's essentially the same as the diameter of the capillaries. Because of this, it's the same as the diameter of the capillaries, the erythrocytes are going to end up having chances of interaction with the cells within the lumen of the vessels, which can end up causing disruption of those cells, which is important because the cells do not have a nucleus, and since they do not have a nucleus, they cannot repair themselves from this damage. The erythrocytes themselves are formed within the bone marrow, in particular the red bone marrow of the long bones. As they mature, they discard their nucleus, which means that when they actually leave the bone marrow, they are essentially metabolically dead, which means that they cannot repair themselves. Because they cannot repair themselves, damage to the erythrocyte leads to death of the erythrocyte. In general, most erythrocytes have a lifespan of 10 to 20 weeks at most before they end up getting recycled. So if we look at the pathway for development, we have the pluripotent cell. This pluripotent cell, underneath EPO regulation, converts to a myeloid stem cell. As EPO is continued to be experienced, that myeloid stem cell will become a CFUE, where CFU is distinguishing what's known as the colony forming unit, which is basically a collection of soon-to-be erythrocytes clustered all together. These CFUEs then undergo differentiation to what's known as a pro-erythroblast, which then undergoes differentiation and maturation into what's known as a reticulocyte. It's at this point in time that the nucleus of the cell gets ejected. This ejection is important because it's going to increase the area for hemoglobin collection, as well as increase the surface area of the cell for interaction with gases. Eventually, this reticulocyte will undergo further maturation into the erythrocyte, at which point in time it will leave and go into circulation. This whole pathway is EPO regulated, where the EPO regulation is based off of the amount of oxygen being sensed within the juxtaglomerular region of the kidneys. We'll get to this feedback loop in a second here. So if we look at the life cycle of the erythrocyte, we start with the formation of the erythrocyte. We then have the formed erythrocyte head into circulation. The diameter of the erythrocyte is essentially the same as the diameter of the capillaries, and as it interacts with the basal membrane as well as the epithelium of the lumen within the capillaries, its cell membrane will have some damage to it. As it has damage to it, it changes the shape of the erythrocyte. As it changes the shape of the erythrocyte will end up getting trapped either within the spleen or within the liver. In either one of these places, it will undergo a macrophagic response, which will digest the erythrocyte. As the erythrocyte gets digested, the hemoglobin molecule gets broken into two distinct components. It gets broken into the iron component. The iron will then get vesiculated, put into a vesicle, and then transported back to the red bone marrow and into the protein component. This protein component will get recycled and converted into what's known as bilirubin, which will then get excreted by the liver as bile or excreted in urine from the kidneys. So let's take a look at the EPO cycle regulating the pathway here. The juxtaglomerular cells of the kidneys will end up sensing a low O2 tension or a low oxygen saturation within the plasma. At the same time, it's going to have a detection for lactic acid. The reason for this is because it needs to be able to differentiate between an acute hypoxic condition due to stress of physical activity from a hypoxic condition due to environmental conditions. This hypoxic condition from environmental conditions is typically seen when people go from areas of lower elevations to areas of higher elevations, where we have a lower oxygen tension within the atmosphere, thus leading to lower saturation within the plasma. This leads to the increase of EPO. Note how we have this inhibitory signal coming from high lactic acid. This inhibitory signal from high lactic acid is due to that differential response from either the hypoxic condition due to stress versus the hypoxic condition due to the environment. This releases EPO into circulation, which then heads to the red bone marrow that stimulates the progenitor cells, which leads to proliferation and differentiation, which leads to the formation of the CFUEs and the maturation into erythrocytes. Note, there's a secondary signal here on the stimulant for the progenitor cells, as well as a stimulant for the formation of the CFUEs, and that's testosterone. And it has to do with the signal that testosterone has for full body growth Now note that when people move from lower elevations to higher elevations, there is a signal that leads to an increase of EPO. This increase of EPO is an attempt to get the O2 carrying capacity back to normal in order to get the oxygen tension as well as the oxygen saturation back to normal. This leads to an increase of erythrocytes and a change of hematocrit. This change of hematocrit is met by an increase in plasma volume. The whole adaptation is lost within 3 weeks of a return to lower elevations. However, people who have been habituated to higher elevations or can trace their evolutionary lineage to higher elevations have a normally higher levels of both red blood cells, erythrocytes, as well as hemoglobin. This has to do with an evolutionary adaptation that they have to these higher elevations. So let's take a look at the counts that we have for our erythrocytes. Now, erythrocytes are going to be highly variable within the person, but in general, they're going to be more variable in females than in males. And it has to do with changes of hemodynamics, particularly around menstruation. For males, we're looking at somewhere between 4.6 and 6.2 million cells per cubic millimeter, whereas for females, we're looking at 4.5 to 5.1 million cells per cubic millimeter. Now, once again, these differences in numbers is all about the size of the individual, which means that if we have equal size male to female, they're going to have roughly the same number of erythrocytes. It's also going to be dependent upon stress as well as environmental conditions as to how much erythrocytes the individual has.